Many females have pregnancy test which is positive, but there is pain in abdomen. Many times the pregnancy test, in spite of being positive, the pregnancy is not seen in the uterus. Most of the females thinks that this is normal. In most of the cases, it might be normal, but sometimes it can be an ectopic pregnancy also. Pregnancy test positive with no pregnancy seen inside the uterus. As a doctor, I always suspect ectopic. I see many patients in my OPD in which, in spite of positive pregnancy test, the pregnancy is not seen in the uterus, and many of them turn out to be ectopic. What is ectopic pregnancy? What is the management of ectopic pregnancy? Why ectopic pregnancy is life-threatening? Why it should be managed on an urgent basis? Can one conceive after ectopic pregnancy naturally? Does one require IUI or IVF only after an ectopic pregnancy? We'll discuss all these questions in today's videos. Good morning, good afternoon, good night, wherever you are. I'm Dr. Rajat. I'm a fertility gynecologist, and you have started watching our YouTube channel, The Fertility Gynecologist. Just to revise, this is the uterus, this is the fallopian tube, this is the ovaries. In every cycle, the sperm comes from here to this place, the egg after the ovulation comes from here to this place, and initial fertilization occurs in the middle part of the fallopian tube. Then that embryo which is formed, that migrates to the uterus inside here, and then it implants. If the embryo does not migrate from the fallopian tube to the uterus and it gets implanted in the fallopian tube only, then we call it as an tubal ectopic pregnancy. Tubal ectopic pregnancy is the most commonest site of ectopic pregnancy. The pregnancy which is not there in the uterus. It can be in cervix, it can be in the interstitium, it can be in the broad ligament, it can be in the ovary, but because 95 to 98% of the ectopic pregnancies are tubal ectopic, we will concentrate on tubal ectopic pregnancy only in this video. Tubes, because they are very thin, they cannot have the pregnancy for more than 6, 8, 10 weeks. And once the pregnancy matures more than 6, 8, 10 weeks, the rupture of that ectopic pregnancy occurs. And the moment the rupture occurs, the bleeding occurs from the tubal blood vessels. That bleeding occurs in the peritoneum, and that can be life-threatening to a female. And that is why, my dear friends, ectopic pregnancy is a medical emergency as far as obstetricians are concerned. A fertilized egg cannot develop normally in a tube, and that fertilized egg or fertilized embryo has to be removed. The products of conception in the fallopian tube have to be removed. Whether that removal method is medical with medicines or surgical, it depends upon various factors. It depends upon when the patient presents to us, whether the patient presents to us early in the phase of an ectopic pregnancy development or late. If the patient presents to us early, there are good chance that that patient can be managed medically. But if patient presents late, the fetal activity has developed or the tubal rupture has occurred, in those cases we would need a surgical management. We will discuss when the ectopic pregnancy can be managed medically, how to do a medical management, what injections to give, what are the side effects, what are the various protocols of an ectopic pregnancy management. Most of the patients have few questions in their mind. How do I diagnose whether an ectopic pregnancy is there? What type of blood tests do I require? What are the chances of a healthy pregnancy after ectopic pregnancy in future? How long to wait for an ectopic pregnancy after ectopic pregnancy to conceive naturally? First of all, what are the symptoms of ectopic pregnancy? Patient would not come and directly tell me that I am having an ectopic pregnancy. Patient would directly come either with a missed period or with missed period with spotting PV, or with missed period plus spotting plus pain in abdomen. And amenorrhea, pain in abdomen, and bleeding or spotting PV is a triad of an ectopic pregnancy which we were taught when we were residents, but in most of the cases this classical triad is not seen. If there is pain, if there is spotting, that can be there in early pregnancy, miscarriage also, it can be there in normal pregnancy also. So as a doctor, we have to be very sure for diagnosis. Vaginal pregnancy occurs in ectopic pregnancy because of the shedding of the decidual cast, because of the progesterone effect. And that can sometimes mimic an early pregnancy bleeding and implantation bleeding, so I have to be very careful as a doctor. Even early pregnancy pain is very, very common because of the stretching of the uterus which occurs. But in an ectopic pregnancy, the pain is typical in an iliac fossa, either right side or left side. It is because of the stretching of the fallopian tube initially. Initially the pain is severe, localized at one point, and once the tubal rupture occurs, the bleeding occurs in the abdomen, the pain becomes generalized and wake over the whole abdomen. We do transvaginal sonography for diagnosis of an ectopic. Once the patient comes to us with a missed period or within scanty periods, we do transvaginal sonography and we try and look initially in the uterus whether the intrauterine pregnancy is seen or not. The moment intrauterine pregnancy is seen, it effectively rules out ectopic in about 95 to 98% of the cases. But if the intrauterine pregnancy is not seen, the secretory changes are seen, then we go on either side of the head neck, the right side or the left side, and we look for the presence of a gestational sac or a yolk sac or fetal cardiac activity. That is how we diagnose. But not in all the cases, ectopic pregnancy can be initially diagnosed on an ultrasound. We first of all, the moment comes to us with missed periods, abdominal pain or spotting or bleeding PV, we do a test called as a urinary pregnancy test. If that pregnancy test is positive and we are not able to see a pregnancy, intrauterine pregnancy on a transvaginal ultrasound, we do a test called as a beta SCG. Like I mentioned in my previous beta SCG videos also. Beta SCG, serial beta SCG is a very important test for ectopic pregnancy diagnosis. Beta SCG is a hormone which is made when an egg and sperm fertilize, they become an embryo, and that embryo starts secreting this hormone called as human chorionic gonadotropin. This human chorionic gonadotropin from the tubal vessels goes to the maternal circulation, and if we do the maternal beta SCG, then we can find this beta SCG usually in 99% of the cases increases at the rate of 49% over 48 hours initially till 1500 international unit per ml. This beta SCG increases at the rate of 40%. From 1500 to 3000 international unit, this beta SCG rate increases at the rate of 33% every 48 hours. And after 3000 international unit per ml, the rate of beta SCG increase slows down. The rate of beta SCG increases till about 1 lakh international unit, and after that, the rate of beta SCG plateaus. If beta SCG is not increasing but is decreasing at the rate of 21% to 35% at the every 48 hours, it gives us an indication that the pregnancy is a failing pregnancy. This is not a good pregnancy. After so many years of research, we have found out that there is something called as a discriminatory zone. Not every urine pregnancy test positive or not every beta SCG test positive would show as an intrauterine or an ectopic pregnancy in an ultrasound. There is something called as a discriminatory zone. And discriminatory zone is the zone after at the level of beta SCG at which the the gestational sac or a yolk sac or a fetal cardiac activity, that means an pregnancy, is seen on an ultrasound. In hands of a good ultrasoundologist, an experienced ultrasoundologist in good ultrasound machine, especially with transvaginal sonography, most of the pregnancies, either intrauterine or extrauterine, should be seen by 1500 international unit of beta SCG. However, if we take this 1500 unit as a lower cutoff, then we are likely to miss most of the viable intrauterine pregnancies. So as a result, after years of research, we have come to a conclusion that discriminatory zone should be kept at 3500 international units so that we do not miss an apparent viable early intrauterine pregnancy. This is very, very important. So the aim of a discriminatory zone and transvaginal sonography is to do three things. One, to document whether this pregnancy is growing, whether it is a potentially viable or a potentially non-viable pregnancy. The rise of beta SCG at the rate of 53% every 48 hours in a patient with pain, symptoms of pain and vomiting, based on the 99th percentile of a confidence interval around the mean curve of SCG rise, suggests that this pregnancy is growing normally. When we were in our residency, we were taught that this rise has to be 66%. But nowadays, that correction has been made. Instead of 66% rise every 48 hours, this rise, we have decided that this rise should be 53% every 48 hours for it to be documented as a potentially viable pregnancy. Declining beta SCG levels, most likely at the rate of 21 to 35% at every 48-hour interval, mostly suggests that this is a failing intrauterine pregnancy, or this pregnancy is going for a miscarriage or a missed abortion. But it does not, however, rule out the presence of an ectopic pregnancy. The absence of a gestational sac with SCG in a discriminatory zone or an abnormal rising or a declining SCG level suggests an abnormal pregnancy, but it does not rule out an ectopic pregnancy from a failed intrauterine gestation. In those cases, it is imperative we do a uterine dilatation and curettage. We curate it out, send the material for a biopsy and to look whether the chorionic villi are present or not. If chorionic villi are present, that suggests to us that this is a failing intrauterine pregnancy and we don't have to do anything further. But if chorionic villi are not present on uterine DNC in a patient in whom the beta HCG is falling, that suggests that this is potentially can be an ectopic pregnancy and we have to monitor according to the ectopic management pregnancy protocol. So whenever we give a diagnosis of an ectopic pregnancy to our patients, the first reaction of the patient is denial, shock, no, this cannot be there. Then when we say, most of the patients want to go for a medical management option only. Although medical management, that means management of ectopic pregnancy with injections, is first line of management, but it is not always the optimal choice for a patient. We as doctors should give an informed choice to the patient that these are the indications of medical management. This will happen if you don't do the medical management. This will happen. These are the cases in which there is a borderline case for a medical management, and these are the cases that this is not a case for a medical management. The incidence of ectopic pregnancy is only 1 to 2%. Ectopic pregnancy is more in females in whom there is a more history of pelvic inflammatory disease, more history of multiple sexual partners, more history of leukorrhea. It is also more in patients who are undergoing an assisted reproductive treatment, IUI or an IVF. But an index of suspicion as a doctor has always to be kept. While maximum number of females, if they are diagnosed early, can be managed medically, but one must remain mindful of advantages and disadvantages of both medical and surgical management of an ectopic pregnancy. While medical management should always be an initial choice, but it should always be discussed thoroughly with the patients, keeping the patient profile in mind, keeping the chances of an absolute must follow-up, an absolute surveillance of the patient. All these things have to be kept in mind. So what do we do in medical management? Which drug, which injection we use for the medical management of ectopic? Methotrexate. Yes, you heard it right. Methotrexate, and originally an anti-cancer drug. It is a folic acid antagonist which acts on and blocks the DNA synthesis by acting on dihydrofolate reductase enzyme. Its main action is on the S phase of the cycle, and as a result it affects mainly the fast growing cells. That is why after giving methotrexate, most of the females or most of the patients complain of mouth ulcers, oral ulcers, vomiting, nausea, because it acts on the fast growing cells, and all the cells of mucosa, epithelial cells of mucosa of GI tract are fast growing cells. Can we give methotrexate in every patient? The good candidates for methotrexate are for those patients who have got a less initial beta HCG level, that is less than 5000. The adnexal mass size is less than 3.5 centimeter. There is an unruptured ectopic pregnancy. Patient is hemodynamically stable. There is no cardiac activity which is seen, and no known sensitivity to the methotrexate. There are some patients who are absolute contraindication for methotrexate medical management. If fetal cardiac activity is present, if tubal rupture has occurred, if patient is not hemodynamically sensitive, is stable, if patient has already some kind of blood dyscrasias, patient has liver or kidney issues, or there is some kind of a sensitivity to the methotrexate. There are some gray areas in which, while methotrexate is not absolutely contraindicated, but the chances of success of methotrexate as a medical management may not be very, very good. Fetal cardiac activity present, beta HCG level more than 5000. And most important, we don't know whether the patient would be able to come to for follow-up or not. Patient of low socioeconomic class status, low IQ patients, those patients are of questionable things to go for a medical management. Like I said, in India, transvaginal sonography is the first line of diagnosis of an ectopic pregnancy. A visible gestational sac with yolk sac or without yolk sac, with or without fetal cardiac activity in adnexa, is almost diagnostic of ectopic pregnancy. Now, diagnosis of ectopic pregnancy by transvaginal sonography is a very difficult skill to master. Most of the times, corpus luteum in ovary appears almost similar to the ectopic pregnancy. There is a ring of fire appearance. There are various blood clots in the cross, and sometimes it gives an appearance which is similar to the ectopic pregnancy. But we have to make it out, we have to border out, map out the ovary, and if that mass, adnexal mass, is inside the ovary, then it mostly rules out the tubal ectopic pregnancy. The tubal ectopic pregnancy is at a different site, different space than a corpus luteum. It should not be in the area of ovary. because we cannot see fallopian tubes on ovary. That is why the diagnosis of tubal ectopic becomes relatively tricky. But for those people who are routinely diagnosing, routinely managing, routinely doing infertility work, for them diagnosis of ectopic pregnancy becomes relatively easy. Sometimes the gestational sac or an yolk sac or a fetal cardiac activity cannot be seen in the uterus. Beta HCG is there in the discriminatory zone, and the pregnancy is not seen in the adnexa also. Such pregnancy we call as pregnancy of unknown locations. How to manage pregnancy of unknown location? Should we give directly methotrexate injection, medical management of ectopic? In those cases, we will come to it in the later part of the video. The success of methotrexate as a medical management depends. The most important defining factor is the initial beta HCG level. I will read out the following levels. If the beta HCG level is less than 1000, then the success rate of methotrexate as a medical management is 98%. If the level is less than 2000, the success rate is 94%. If the level is less than 5000, then the success rate is 96%. After 5000, the success rate dramatically decreases. From 5000 to 10,000, the success is 85%, and more than 10,000 to 15,000, the success rate is 81%. So the summary is that beta HCG, if it is more than 5000, the chances of medical management success, they decrease, and after 10,000, they dramatically decrease. So how do we give methotrexate for the management of an ectopic pregnancy? There are multiple protocols. Initially in 1982, methotrexate, we actually knew beforehand that it was used. It was a wonderful drug used in the management of choriocarcinoma. Choriocarcinoma is basically a tumor in which the trophoblastic cells, they invade various tissues. And since pregnancy, ectopic pregnancy is also a trophoblastic tissue, the moment the choriocarcinoma is 100% treatable by methotrexate, so people thought, why not use methotrexate for managing the trophoblastic tissue which is outside the uterus, and that is how the methotrexate started to be used in the management of a medical management of ectopic in 1982. Initially, just like choriocarcinoma, multiple dose of methotrexate was given. 0.1 milligram per kg per day, alternate day doses was given, and an alternate day, 1 milligram per kg per day of methotrexate was given, along with 0.1 milligram per kg per day of a leucovorin, that is a folinic acid rescue, because like I mentioned, since methotrexate is a dihydrofolate reductase inhibitor, so it causes the deficiency of folic acid. So folinic acid rescue is given so that the side effects of methotrexate are less. This injection is given on alternate day. It can be given for a maximum 4 doses, and the target should be that there should be 15% decrease of beta HCG every 2 doses. Up to 4 doses can be given, but not all the patients require all the 4 doses, and the success chances of this protocol is about 96%. This was the protocol which, when I used to study my gynec in my residency days about 20-25 years back, most commonly it was used. But it involved use of 2, 3, 4 doses of methotrexate. So people thought, can we have the advantage of methotrexate while reducing the dose of methotrexate? And that is how the one dose protocol of a methotrexate was born in 1991. It was a single dose protocol, methotrexate 50 milligram per meter square. Mind you, 50 milligram per meter square. Our basal, basically it is according to the body surface area. There are nomograms available. We calculate the body weight, we calculate the height, we put the body weight and the height on the nomograms, and we can calculate that what is the exact body surface area. In average Indian female, the body surface area comes to about 1.5 to 1.7. So 50 milligram per meter square single dose methotrexate is given to the females stat after taking the blood test for the beta HCG. Normally, since methotrexate can be toxic to liver and can be toxic to kidney, we do all preoperative major blood investigations like CBC, like LFT, like RFT to rule out the toxicity, and then we give methotrexate. The advantage of single dose is that it does not require a leucovorin rescue, and then we do serial beta HCG levels at day 4, day 7, and then every weekly thereafter. Our target is, initially, the day 4 levels slightly beta HCG increases because of the separation of the ectopic pregnancy from the fallopian tube, but between day 4 to day 7, our target should be 15% decrease of beta HCG levels. Day 7 value, if the 15% beta HCG drop level is not documented, then we can repeat the single dose of methotrexate. The success chances of single dose of methotrexate earlier was documented to be about 94%. However, since those values did not account for the failing intrauterine pregnancy, the correction has come, and the success rate nowadays ranges between 86 to 90%. Since the success rate of single dose methotrexate was not comparable to the multiple dose, people came up with a novel 2-dose protocol. This 2-dose protocol, it was invented to maintain the efficacy and convenience of a 2-dose protocol and to maximize the effectiveness of methotrexate without the requirement of a leucovorin rescue. We give 2 doses of methotrexate at day 0 and day 7, and while maintaining the same surveillance what we do in the single dose. We check beta HCG on day 4, we check beta HCG on day 7, and then every weekly we check. Again, the 15% decrease after 48 hours, the rate has to be documented, and if patient is monitored, as long as there is a 15% decrease in the beta HCG level, the moment 15% decrease in the beta HCG level is not there, or there is hemodynamically instability, or there is an evidence of a rupture of fallopian tube, then we take the patient for a surgical management. Close follow-up is an absolute must for a medical management of ectopic pregnancy. In an ideal world, especially in medical colleges, for the patients for medical management of ectopic, they are admitted. But in private practice, in today's world, it is very difficult because to admit a patient, it would become expensive for the patient. If patient is hemodynamically stable, patient can come for close follow-up, routine follow-up. Patient is not living very far. In those cases, we can allow the patient to go home, but with a guarantee that patient will come for a routine follow-up. Between day 1 to day 4, it is usual to have some kind of abdominal pain that is called as a separation pain and some kind of bleeding. That is absolutely normal. As long as it does not increase in severity, as long as there is no hemodynamically instability, that can be managed symptomatically. The side effects of methotrexate are mostly gastrointestinal nausea, vomiting, abdominal pain, some spotting, that is fine. But few precautions have to be taken while managing the patient medically. A. Folic acid should not be given because methotrexate is a folic acid antagonist, and if you are giving folic acid, it will decrease the efficacy of folic acid. No non-steroidal anti-inflammatory drugs like brufen, like diclofenac, like paracetamol should be given for patients with abdominal pain in an ectopic pregnancy, because they might mask the symptoms of pain, which might give us a pseudo confidence that patient is apparently well, and we may not diagnose the rupture of ectopic in time. Pelvic examinations, PV examinations, and transvaginal sonography should not be done because undue pressure may cause rupture. We also ask patient not to do heavy work, not to engage in sexual intercourse, and mostly the patient should be not doing complete bed rest but in a state of rest with no physical exertion. From my personal experience, we ask patient whenever they go to toilet or bathroom, they should not close the door, because sometimes if they go and they have to strain on urine or stool, passing stool or urine, that might suddenly provoke a rupture and they may fall unconscious in the bathroom. And if the bathroom door is closed from inside, it may create problematic condition. So we tell the relatives of the patient and the patient also, whenever you are alone in home or room, you should not close the door, you should not close the latch from the inside. Keep it open so that if some untoward event happens, somebody may come out and help you. Sun exposure should be limited because methotrexate can cause dermatitis, and also the foods which form gas, acidity, and all those should be avoided. The common side effects of methotrexate, like I said, the ulcers in the mouth and the tongue, nausea, vomiting, diarrhea, mostly are gastrointestinal. They can be managed. The severe and the rare side effects are nephrotoxicity, interstitial pneumonia, alopecia, dermatitis. I have not seen those side effects. Now comes a very common condition which I touched upon earlier in my video, that is a pregnancy of an unknown location. I mentioned one word that as a gynecologist we have to keep a very high index of suspicion for diagnosis of ectopic pregnancy. If urine pregnancy test is positive, we are not able to see pregnancy, intrauterine pregnancy on ultrasound, we must think that it is ectopic. But that does not mean that any pregnancy which is not seen intrauterine initially is always an ectopic pregnancy. Yes, we must keep a high index of suspicion, but we should not label it an ectopic pregnancy, and we should not directly start the medical management of ectopic pregnancy. First of all, we need to do initial beta HCG level. we need to see whether that level is in the discriminatory zone or not. Earlier, discriminatory zone used to be in the 1500s level. Nowadays, to avoid the chances of a potentially viable intrauterine pregnancy being misdiagnosed as an ectopic pregnancy, we have increased the level of discriminatory zone to about 3000, 3500. If the beta HCG level is 3500 international units per ml and still we are not able to document a intrauterine pregnancy or a extrauterine pregnancy in the adnexa, then we call that pregnancy as a pregnancy of undisclosed or an unknown location. How do we manage such cases? In such cases, to know whether that pregnancy is a failed intrauterine pregnancy or potentially an ectopic pregnancy, we do a dilatation and curettage. We curate out the decidua of the uterus, send it for the biopsy. If on biopsy the chorionic villi are seen, that means that that patient is likely having a failed intrauterine pregnancy or an intrauterine pregnancy. If chorionic villi are not seen, it suggests that it might be an ectopic pregnancy, and in those cases we can start a medical management of an ectopic pregnancy protocol. Initial level of beta HCG is very important to decide whether we require a single dose protocol or a double dose protocol. If initial level of beta HCG is less than 3600 international units per ml, in those cases the chances of a single dose protocol being successful are very high. But if initial level of beta HCG is more than 5000 international units per ml, then we should go for a double dose protocol. Like I said, 15% reduction of beta HCG between day 4 to day 7 and after day 7 is very, very important. Some people came up with a novel hybrid protocol in which we give methotrexate on day 1 and day 4 instead of the second dose on day 7 in a 2-dose protocol. It is a hybrid protocol in which we give methotrexate on both day 1 and day 4, and then we follow rest same as a multiple dose protocol. It has an optimal balance between convenience and efficacy, and the success chances are relatively more than a conventional 2-dose protocol. Separation pain I have mentioned between day 3 to day 7. Once the effect of methotrexate starts appearing, it decreases the blood supply from the embryo to the wall of the fallopian tube, and as a result there is a mild pain, the separation pain, and this pain can be managed. Mostly it is not severe, it is mild, but if it is severe and persistent, then it is prudent to roll out the rupture of an ectopic. We need to do a hematocrit per pack cell volume to find out whether the rupture has occurred or not. Rupture ectopic mostly occurs in case of increasing beta HCG in spite of giving methotrexate. The chances of rupture after medical management of ectopic is about 7 to 14%. The complete resolution of ectopic usually takes 2 to 3 weeks. Sometimes it can take about 5 to 6 weeks also. Sometimes ectopic, once when we give the medical management of ectopic, if the tissue it basically dries there, but very rarely the chances of that side fallopian tube being blocked also occurs. But what we have found is in 78% of the cases, if we do the HSG next cycle, in 78% of the cases the fallopian tubes are patent. I have had an interesting case. There was a bilateral ectopic pregnancy in both the fallopian tubes. Normally bilateral ectopic pregnancy is not an indication for medical management, but patient had a primary infertility. If I take the patient for a surgery, even if I do the salpingostomy, which I'll come to it later, the chances of recurrent ectopic would be there. I took the patient into confidence, I counseled the patient, and we started the medical management. By God's grace, everything was fine, the ectopic pregnancy was resolved. And immediately, next cycle, I did an hysterosalpingography. And luckily that came out to be patent. So we not only managed the bilateral ectopic, we also managed to save the fallopian tubes of that patient. We managed to decrease the cost expensive of that patient by not going for the surgery, and because both fallopian tubes were patient, there is a good chance that patient can conceive in the future also. Sometimes methotrexate is not given for the medical management, but it is given as an adjunctive management to a different treatment. Suppose I have done a salpingostomy for a patient of a medical ectopic, removed the tissue. For some remaining tissue, single dose methotrexate can be given as a prophylactic measure when the incomplete evacuation is likely. There is something called as an heterotropic pregnancy, and it is more common in IVF pregnancies when more than one embryo is transferred. One pregnancy is in the intrauterine and one pregnancy is in the fallopian tubes. It happened to me with a normal pregnancy in normal patient also. I gave clomipene citrate. There were 3 follicles formed, and after trigger, patient went to some other city. Patient calls me after 6 weeks that there is a one intrauterine pregnancy and excuse me, one extrauterine pregnancy. In those cases, surgical management is the treatment of choice. Means medical management is not the treatment of a choice for a heterotropic pregnancy, especially when the patient wants a pregnancy, because medical management of pregnancy would also harm the intrauterine pregnancy. So this is very, very important. Again, sometimes the pregnancy is in the interstitium. This is the most vascular area of pelvis, and this interstitial pregnancy can grow up to 16 weeks. So if the pregnancy is in the interstitium or in the cornu area, that is a very difficult thing. There are very high beta hCG levels, and only treatment with methotrexate may not be beneficial. Direct intrauterine injection of potassium chloride, intracardiac injection of potassium chloride with methotrexate as an injection is helpful, and these pregnancies can rupture and then they can lead to a torrential bleeding. Because, and if the patient does not want pregnancy, the family family is complete. In those cases, we may opt for an emergency hysterectomy. Cervical pregnancy is also a rare pregnancy in which, although methotrexate can act if it is given early, but like I said, because the implantation is in the cervix and the uterine is very near, if it ruptures, there can be a massive torrential bleeding. In those cases, also a direct injection of intracardiac injection of potassium chloride along with methotrexate helps. But again, if the family life is complete, that hysterectomy should be considered. If the patient is not a candidate for a medical management of an ectopic pregnancy, then we go for a surgery. Surgery can be done by a laparoscopy or a laparotomy. Nowadays, most of the people are doing laparoscopy only. You put a camera inside the uterus, look where the pregnancy is. If on table the pregnancy is not ruptured, then we have got two options: salpingostomy or salpingectomy. Salpingostomy is we open the tube, take the contents of the pregnancy out and let the tube open only. Tube will heal by itself. But if it is a ruptured ectopic pregnancy, there is blood in the peritoneal cavity, then there is no point of saving that tube. Tube cannot be repaired, tube cannot be taken stitches or by any method. We have to remove the tube. But if it is an unruptured ectopic, we can go for a salpingostomy. Salpinx means fallopian tube, ostomy means we just cut, take the products out and let that wound open, and that wound will get closed by itself, just in hope that fallopian tubes remains patent. However, all the literature suggests that the moment these fallopian tubes are very delicate structures, an ectopic pregnancy means the cilia of the fallopian tube has damage, and even if we leave that ostomy open, the healing of fallopian tube may cause cicatrization and fibrosis of the fallopian tube, and as a result, there are chances that there may be a recurrent ectopic in that fallopian tube. So if there is an unruptured fallopian tubal ectopic pregnancy, we can go for a salpingostomy. But if that that ectopic pregnancy patient has had a history of fallopian tube ectopic in the past, then it is better to go for a salpingectomy. I have seen, if the ectopic pregnancy is in the ampullary part or in the infundibular part of the fallopian tube, people do a subtotal salpingectomy. They only remove the part of the ectopic pregnancy. I have seen, even after removing of the fallopian tube, the ectopic pregnancy occur in the remaining part of the fallopian tube also. So it is better to remove whole fallopian tube if there is a need for a salpingectomy. Total ruptured fallopian tube must be done. There is something called as an expectant management of ectopic pregnancy. If the beta hCG levels are less than 1000, they are not increasing, then we can do serial beta hCG levels every 4 to 7 days, and if they are decreasing at the rate of more than 15%, we do not need to do anything. Those things are mostly a case of a tubal abortion. Sometimes the fallopian tube ectopic occurs in the tube, and that pregnancy comes out from the fallopian tube inside the abdomen only, that we call as a tubal abortion. In those cases, we can do an expectant management. We can admit the patient, monitor the vitals, do a serial beta hCG, and if initial levels are less than 1000 and they are decreasing, then in 88 to 90% of the cases, they resolve by themselves. Once an ectopic, always think of an ectopic, was a dictum which we were told, which we were taught when we were doing our residency. So a past history of an ectopic pregnancy should always think patient must also be aware that there can be an ectopic pregnancy. Next time, even if she misses period or even if she does not miss period, it is better to do urine pregnancy test, or even if there is a scanty period, always do a urine pregnancy test and report to the doctor immediately. When can a patient of an ectopic pregnancy plan to conceive after the medical management of ectopic pregnancy? If there is a single dose methotrexate has been given, then we advise the patient to leave one ovulatory cycle after the complete beta HCG resolution, and then they can try after one ovulatory cycle. But conventionally, I advise to wait for at least 3 cycles. Since methotrexate is an anti-cancer drug, it would have an effect on the follicle, and that follicle, the life cycle of the follicle is about 90 to 100 days. So I would advise 90 to 100 days to at least pass after giving the last injection of methotrexate, and then the patient should try to conceive. Once the beta HCG has become 0 after 3, 4, 5 weeks, the complete resolution of beta HCG is an absolute must. Once beta HCG has become 0, then I gave a good 3 weeks course of doxycycline. I gave a good course of probiotics, because I firmly believe that most likely ectopic pregnancy is because of pelvic inflammatory disease. Pelvic inflammatory disease damages the cilia. While that damaged cilia cannot be reversed and that cannot come back to normal cilia, but whatever further damage should not occur, and that is why I give 3 weeks course of a doxycycline along with a good liberal dose of pre and probiotics till the patient conceives. And I have found this method very, very helpful in my practice. There have been at least 5 to 10 patients who have conceived, delivered after getting a medical management of ectopic pregnancy done at my place. Most of the people fear after the removal of one fallopian tube that their chances of pregnancy would be less. Yes, overall chances are less, but they usually do not find problems with conceiving. Most of the people conceive with single fallopian tube also. So in summary of ectopic pregnancy medical management, while it is definitely the first line of management of an ectopic pregnancy, it is not always the optimal line of management. Patient should be thoroughly counseled, and as a doctor you have to make sure that patient would be always coming for visits. Follow-up is an absolute must for a medical management. Patient should be mentally ready that any time the beta HCG is not falling, or any time that hemodynamical instability occurs, there are potential signs of rupture, then immediately medical management has to be converted to the surgical management. So if I am doing a medical management, I cannot be just running an OPD and do a medical management. I need to have a emergency surgery facilities at my place. That is a very, very important. Serial HCG surveillance till HCG levels are undetectable, and multiple visits, they are an absolute must. Surgical management is safe in the regard that it requires minimal visits, and it should be especially considered for those patients who have completed their family, and along with the surgical management, a tubal sterilization can also be done at the same sitting. So that will give us double advantages. So a suitable case selection is an absolute must. It is an imperative to confirm diagnosis of an ectopic pregnancy before starting the management, to prevent the chances of a potentially viable intrauterine pregnancy being given in methotrexate. If the patient is desiring a pregnancy, then in that case, the potentially viable intrauterine pregnancy, which might not have appeared at the discriminatory zone, which might appear a couple of days later, it should be given a chance to appear. So diagnosis is an absolute must. The choice between a medical management and a surgical management should be informed, well-informed patient. Their relatives should be informed of pros and cons of both medical and surgical management. How much follow-up would be required, what would be the cost, what would be the surveillance, and that there are chances that medical management may need to be converted to surgical management at any point of time, either in 2 days, 2 weeks, or 3 weeks. It should not be reflective, it should not be forced upon the patient. While yes, the decision sometimes is biased by the experience of a doctor. See, I have done about 20 medical management of ectopic pregnancies till now, and I do infertility treatment. I know if I do a surgical management, most likely the patient will go for a salpingectomy, and that would decrease the chances of normal conception in future. And that is why my first preference always, if the patient fits in the criteria for a medical management, is a medical management. If that medical management fails, then in that case only I go for a surgical management. Discriminatory zone should be increase from 1500 to 3500 to avoid the potentially viable intrauterine pregnancy, especially in those patients who are desirous of pregnancy. An endometrial biopsy should be considered to see or to rule out the presence or absence of chorionic villi to differentiate a potentially failing intrauterine pregnancy from a pregnancy of an unknown location or an ectopic pregnancy. While a single dose of a methotrexate protocol is recommended for almost all the cases, it may not always work. You should be flexible. You should be able to or willing to convert it into a double dose protocol or a multiple dose protocol. Multiple dose protocol definitely has got a lower failure rate than a single dose protocol. But single dose protocol should be also kept as a adjunctive management after a salpingostomy or for persistent ectopic pregnancies. And medical management of ectopic is always better when the initial beta hCG level is low rather than high. At the end of the video, I would like to request all to please like the video, to please comment. Please comment on further topics you would like to see the video on. And also please subscribe to our channel. Please share the video. Thank you. Bye bye. Namaskar.